Welcome to vpod.ai. We're here to help make complex topics clear and give you actionable insights. And this deep dive is sponsored by Stonefly. They're your trusted solution provider for, well, pretty much all things data, enterprise storage, backup disaster recovery, hyperconverged setups like VMware, Hyper-V, Proxmox clusters, even AI servers. Plus, they offer SA365, a turnkey security appliance, and deep expertise in public and private cloud solutions. You can check out how Stonefly can help simplify your tech at stonefly.com. So today we're taking a deep dive into esophageal cancer. And, it's a topic that really underscores why understanding these things matters. Here's a fact that really stopped me in my tracks. Esophageal cancer has one of the lowest 5-year survival rates of all cancer types. We're talking just 20%.
It's stark.
Yeah. And to put some numbers on it, around 20,000 people were diagnosed back in 2021 alone. It's a tough reality, and exactly why we wanted to explore this today.
It really is a significant health challenge, impacting so many lives. Our goal here really is to give you a clearer picture. We'll unpack, what esophageal cancer actually is, look at the different types, understand the risks, and then dive into how it's diagnosed and treated today, including some cutting-edge stuff.
Right. And we'll also touch on prevention, which is obviously key, and the role of clinical trials and supportive care in this fight. We want you to come away feeling well-informed, maybe with a fresh perspective. So let's start right at the beginning. What exactly is esophageal cancer?
Okay, so at its most basic level, esophageal cancer starts when cells in the lining of your esophagus begin to grow out of control. Your esophagus, think of it as this muscular tube, maybe 8 inches long. It acts like a pipeline, basically, connecting your throat down to your stomach.
Part of the digestive system carrying food down.
Exactly. It's lined with this moist pink tissue, the mucosa, and that's usually where these cancerous changes first kick off.
And it's not something that just appears overnight, right? I gather these tend to develop slowly over years sometimes.
That's absolutely right. They tend to develop pretty gradually. Often there are precancerous changes happening in that inner lining, the mucosa, well before any symptoms become obvious. Another thing to note is it's more common in men than women, and many cases have pretty clear links to things like tobacco, alcohol, or excess body weight.
Okay, so when we talk about esophageal cancer, is it just one disease, or are there different types we need to understand?
That's a great question. There are 2 main types, and knowing the difference is really crucial because, well, it impacts treatment quite a bit. First, you have esophageal squamous cell carcinoma. We usually just call it ESCC.
ESCC, got it.
Yeah, this type starts in those thin, flat cells lining the esophagus. Historically, ESCC was much more common in places like Eastern Europe, Asia, and Africa.
And the other main type is esophageal adenocarcinoma, EAC. I've read that one's been increasing quite a bit, especially here in the West.
You're spot on. Esophageal adenocarcinoma, or EAC, starts in the cells that actually make mucus within the esophagus. And yes, it's really become the dominant form now in North America and Western Europe. We've seen a very sharp rise in its incidence, particularly over the last 40 years or so.
Wow, 40 years.
Yeah. So understanding which type it is and exactly where it is in the esophagus, that directly shapes the treatment strategy.
Makes total sense. Okay, let's dig into the why. Understanding the risks, I think, can be really empowering for people. Tobacco seems like a big one for both types, and being over 60.
Yep, those are definitely common threads. Tobacco smoking or chewing is a major risk factor for both ESCC and EAC. Age is significant too. Both are more common in folks over 60. And as you mentioned, it's more common in men, sometimes 3 to 8 times higher. Also, things like a low intake of fruits and vegetables and the related micronutrient deficiencies seem to play a role in both forms.
Okay. What about risks that are more specific to the squamous cell type, the ESCC?
Right. For ESCC, there's a really strong connection to both tobacco and alcohol. And what's striking is the synergistic effect.
Meaning they multiply the risk together.
Exactly. Over 3/4 of cases in men are linked to smoking and heavy drinking combined. It's not just additive, it's multiplicative, a really dangerous combo. Other ESCC risks include regularly drinking very hot beverages, think over 149 Fahrenheit or 65 Celsius.
Really? Hot drinks.
Yeah. Also, ingesting caustic substances, high dietary exposure to nitrosamines. You find those in processed meats, barbecued meats, and pickled vegetables. We also see links with lower socioeconomic status, poor oral hygiene, and this is important in Asia, chewing betel nut. And there are even some known genetic susceptibilities involving specific genes.
That's a lot to consider. Okay, shifting to the other type, adenocarcinoma or EAC, I always hear about its linked to chronic acid reflux, GERD. How does that work?
That's correct. The number one risk factor for EAC is long-term gastroesophageal reflux disease, GERD. What happens is, over time, that constant acid exposure can damage the esophageal lining and lead to a condition called Barrett's esophagus.
Barrett's esophagus.
Yeah,
That's where the cells actually change.
precisely. The normal squamous cells get replaced by abnormal glandular-type cells. These cells are precancerous and significantly increase the risk of developing EAC. Abdominal obesity is another big one for EAC. It's strongly associated, possibly the strongest obesity-related cancer risk we know of, partly because it increases GERD and chronic inflammation.
Okay, and this is where it gets kind of counterintuitive, right? The H. pylori bacteria. I thought that was bad for the stomach.
It is, generally. H. pylori can cause GERD and is a risk factor for stomach cancer, but quite surprisingly, it seems to protect against EAC.
Protect. How?
Well, the leading theory is that it might reduce stomach acid production overall, and the fact that H. pylori infection rates have been declining in Western countries might actually be contributing, ironically, to the rise in EAC we've seen.
Wow. That really shows how complex the body's ecosystem is.
It absolutely does. Another interesting factor for EAC is that female hormones might offer some protection, which could explain why it's less common and develops later in women. And while tobacco smoking does increase EAC risk slightly, alcohol hasn't been conclusively linked to the specific type, unlike with ESCC.
Okay, so we understand the risks better. Now, what about recognizing it? What are the common signs and symptoms people should look out for? And how do doctors actually figure out if it is cancer?
Yeah, the early symptoms often relate to eating. The most common one is difficulty swallowing. That's called dysphagia. It might feel like food is sticking. Other signs can include nausea, vomiting, maybe regurgitating food, and sometimes coughing, especially after swallowing, which can increase the risk of aspiration pneumonia if food goes down the wrong way.
And if the cancer progresses, what might happen then?
In more advanced stages, symptoms can become more severe. You might see bleeding from the tumor surface, maybe showing up as vomiting blood. The tumor could press on nearby structures, causing problems like upper airway obstruction. Hypercalcemia, too much calcium in the blood, can also occur. And if it spreads, metastasizes, symptoms depend on where it goes. Common sites are nearby lymph nodes, the liver, which might cause jaundice or abdominal swelling the lungs, leading to breathing problems, or even the bones.
So a range of potential signs. How do doctors investigate these symptoms? What tools do they use for diagnoses?
The main tool typically is an endoscopy, specifically an EGD esophagogastroduodenoscopy.
Blast the camera down the throat.
Exactly. A flexible tube with a camera lets the doctor examine the lining of the esophagus, stomach, and the first part of the small intestine. They can see any suspicious areas and take biopsies, small tissue samples right then and there. Imaging tests are also absolutely crucial. CT scans, often of the chest, abdomen, and pelvis with contrast dye, give detailed 3D pictures to see the tumor and check for spread. And PET-CT scans are often used too. They use a radioactive tracer, usually FDG, that cancer cells tend to soak up because they're metabolically active. This helps highlight the primary tumor and any metastatic spots.
And I've heard about endoscopic ultrasound, EUS. How does that fit in?
Ah, yes. EUS is very important for staging. It combines that endoscope camera with ultrasound. It gives incredibly detailed views of the esophageal wall itself, showing how deeply the tumor has grown. It's also excellent for checking nearby lymph nodes and organs for any spread. It's like getting an inside-out ultrasound.
Okay, and biopsies are key for confirming cancer, right?
Right. Absolutely. Tissue is essential for diagnosis. Biopsies are usually taken during the EGD. For very early stages, sometimes it's a technique called endoscopic mucosal resection, EMR, or endoscopic submucosal dissection, ESD, can remove the suspicious tissue for analysis. If needed, fine needle aspiration can get samples from deeper areas or lymph nodes. And in advanced cases, if getting tissue is tough, a liquid biopsy, just a blood test, can sometimes detect cancer DNA circulating in the blood.
That's amazing. And then there's biomarker testing. That sounds like it really personalizes the treatment approach.
It's a complete game changer, honestly. Biomarker testing or molecular testing, tumor profiling, is vital now for guiding treatment. We analyze the tumor tissue, or sometimes the blood, looking for specific genetic mutations or protein levels. Think of them as unique barcodes on the cancer cells.
Like HER2. I've heard of that one.
Exactly. HER2 is a common one. If a tumor is HER2 positive, it means it has too much of a growth protein, and we have specific targeted drugs to block that. We also look for other markers like MSI status, PD-L1 expression that's important for immunotherapy, and rare mutations like NTRK gene fusions, RET fusions, or BRA V600E mutations. The results tell us which targeted therapies or immunotherapies might be most effective for that specific patient's cancer.
And you mentioned performance status earlier. How does that factor in?
Right, performance status, often measured using scales like ECOG or Karnofsky, is a way to assess the patient's overall fitness and ability to handle daily activities. Are they fully active or are they weak, maybe spending a lot of time in bed? This is really important because it heavily influences which treatments a person can realistically tolerate and benefit from. A major surgery or intensive chemotherapy might not be suitable for someone with poor performance status.
So all this information, the type, the location, the depth, the spread, the biomarkers, the patient's fitness, comes together to determine the cancer stage.
Precisely. Staging is critical. Esophageal cancer usually gets staged twice. First, there's the clinical stage, based on all those tests before treatment starts. Then, if surgery happens, there's the pathological stage, based on examining the actual removed tissue and lymph nodes. We use the TNM system, tumor, node, metastasis, which is the standard way to describe how large the primary tumor is, whether it's spread to nearby lymph nodes, and if it has metastasized to distant sites. This stage provides the roadmap for treatment planning.
Okay, so once the roadmap is clear, we know the type, the stage, the patient's situation. How is esophageal cancer actually treated? I understand it's usually a team effort.
Absolutely. A multidisciplinary team, or MDT, is really the gold standard for managing esophageal cancer. This team brings together specialists like gastroenterologists, surgical oncologists, medical oncologists, radiation oncologists, pathologists, radiologists, and, very importantly, supportive care specialists like dietitians, psychologists, social workers, maybe even spiritual care providers, and smoking cessation experts.
So everyone contributes their expertise.
Exactly. It ensures all aspects of the patient's situation are considered, leading to a comprehensive, holistic treatment plan.
And the goals of treatment must vary quite a bit, depending on the stage.
They do. For localized disease cancer that hasn't spread widely, the goal is usually curative. We aim to eliminate the cancer entirely, often using a combination of treatments, typically including surgery. But if the cancer is widespread, metastatic, or if it comes back after initial treatment, the focus shifts more towards palliative care. The goal then is to extend survival as much as possible, but also, critically, to manage symptoms and maintain the best possible quality of life.
Okay, let's talk specifics. What are the main treatment methods, starting with those very early stages or precancerous conditions like Barrett's?
For very early disease, like high-grade dysplasia in Barrett's or tiny cancers confined to the very surface layer, TIS, T1A, maybe some T1B, endoscopic therapy can often be curative. We mentioned EMR and ESD earlier. These techniques allow doctors to basically shave off the abnormal tissue using an endoscope without major surgery.
But sometimes they combine that with ablation.
Yes. Often. After removing the visible abnormality, ablation techniques are used to destroy any remaining potentially precancerous cells in the area. This could be cryotherapy, which freezes the cells, radiofrequency ablation, RFA, which uses heat from radio waves, or photodynamic therapy, PDT, which uses a light-activated drug.
So, minimally invasive options for the earliest stages. When does major surgery, the esophagectomy, come into play?
Esophagectomy, removing part or all of the esophagus, is the main treatment for potentially curable cancer that's grown deeper into the wall or spread to nearby lymph nodes, but hasn't spread distantly. It is a major operation. The surgeon removes the cancerous section of the esophagus and nearby lymph nodes. Then they need to reconstruct the digestive tract, often by pulling up the stomach or sometimes using a piece of the colon or small intestine to connect the throat to the stomach again.
A huge undertaking.
Yeah.
And the goal is clear margins.
That's the crucial surgical goal. Achieving negative or clear margins. It means the edges of the tissue removed show no cancer cells under the microscope. This offers the best chance of removing all the cancer and preventing recurrence.
Okay, beyond surgery and endoscopy, what about therapies that treat the whole body, systemic therapies?
Right, systemic therapies travel through the bloodstream to reach cancer cells anywhere in the body. Chemotherapy is a cornerstone. Chemo uses drugs to kill fast-growing cells. It's often used before surgery, that's neoadjuvant chemo, to shrink the tumor and make surgery easier or more effective. Sometimes it's given after surgery adjuvant chemo to kill any leftover cells. It can also be the main treatment for advanced cancer or used palliatively. Common drugs include cisplatin, fluorouracil, 5-FU, and oxaliplatin.
And sometimes chemo is combined with radiation.
Yes, very often. That's called chemoradiation. Combining the two can make the radiation more effective at killing cancer cells. It's frequently used before surgery for both types of esophageal cancer, and it can also be the main treatment, especially for patients who aren't candidates for surgery or for ESCC.
Now, what about the newer approaches like immunotherapy and targeted therapy? How are they changing things?
They're making a huge difference, especially for advanced disease. Immunotherapy aims to unleash the patient's own immune system to fight the cancer. Drugs called checkpoint inhibitors like nivolumab and pembrolizumab are now standard options in certain situations, often based on that PD-L1 biomarker test.
So they take the brakes off the immune system.
In a way, yes. They help T cells recognize and attack cancer cells more effectively. Targeted therapy is even more specific. Based on those biomarker tests, we talked about HER2, NTRK fusions, BRAF, RET. We can use drugs designed to attack those specific molecular vulnerabilities driving the cancer's growth. It's truly personalized medicine.
And lastly, radiation therapy on its own.
Radiation therapy uses high-energy rays to destroy cancer cells. It can be delivered from outside the body, external beam radiation therapy, or EBRT, or sometimes internally, called brachytherapy. It's used in chemoradiation, as we mentioned, sometimes as the main treatment if surgery isn't an option, and also very effectively for palliative care, like shrinking a tumor to relieve swallowing problems or pain.
It's clear there are many tools in the toolbox,
Yep.
and they're constantly improving. That's where clinical trials come in, right?
Yeah.
Offering access to the next generation of treatments.
Absolutely critical. Clinical trials are how we make progress. They test new drugs, new combinations, new surgical techniques, new radiation approaches. Participating in a trial can give patients access to potentially breakthrough therapies years before they become widely available. And it's important to know that trials are generally free to enroll and the research costs are covered by the sponsor. Plus, a patient always has the right to leave a trial at any time for any reason. They really are at the forefront of cancer care.
That's so important to emphasize. Okay, beyond directly treating the cancer, there's this whole other vital aspect. Supportive care, and also thinking about prevention. Tell us about supportive care.
Supportive care, sometimes called palliative care, even when treatment is curative, is focused on managing symptoms and side effects and improving quality of life throughout the entire cancer journey. It's not just about end-of-life care. It starts right from diagnosis. This includes managing physical symptoms like pain, fatigue, nausea, swallowing difficulties, which can be a big issue, or things like dumping syndrome or reflux after surgery, even nerve damage from chemo called neuropathy. But it's also about addressing emotional, psychological, social, spiritual, and even financial challenges that come with a cancer diagnosis. Nutritionists, psychologists, social workers, they are key members of the team providing this essential care.
Focusing on the whole person, not just the disease.
Exactly.
So flipping back to the beginning, given what we know about risks, what can people actually do to lower their chances of developing esophageal cancer? Lifestyle seems huge here.
It really is. Some of the most impactful prevention strategies are lifestyle-based. Number 1, don't use tobacco in any form. Stopping smoking or chewing is crucial. Avoiding excessive alcohol consumption is also key, especially for ESCC risk. Maintaining a healthy body weight is important, particularly for reducing EAC risk linked to obesity and GERD. Regular physical activity helps too.
What about diet?
Dietary choices matter. Increasing your intake of fruits and vegetables is protective. On the flip side, reducing intake of salt, pickled vegetables, and processed or barbecued meats might lower risk, particularly for ESCC by reducing nitrosamine exposure.
And screening or early detection for those at high risk.
Yes, for individuals known to be at high risk, like those with long-standing GERD or diagnosed Barrett's esophagus, endoscopic screening is recommended. Catching Barrett's early allows for monitoring and potential treatment like RFA to prevent it from progressing to cancer. This has shown real promise in reducing cancer risk. And interestingly, looking back at some older, large studies, particularly one in a high-risk area of China called Linxian,
Oh yeah, what did that find?
it found that daily supplementation with a specific mix of micronutrients, alpha-tocopherol, a form of vitamin E, beta-carotene, and selenium, actually reduced overall cancer mortality, including stomach cancer, especially if people started taking it when they were younger.
That's fascinating. A hint that specific nutrients might play a protective role, at least in certain populations.
It suggests that, yes, though more research is always needed, but it points towards the complex interplay between diet, environment, and cancer risk.
Wow. We have certainly covered a lot of ground today, really navigating the complexities of esophageal cancer, from, the basic biology and the risk factors right through to diagnosis, to different treatments and prevention. What really strikes me is just how much science is uncovering about this disease, leading to more personalized, more powerful tools for patients. And it really highlights that as a patient or a loved one, you're a key part of the care team. Open communication is just so vital for making good decisions.
Absolutely. And I think the journey through understanding a complex health issue like this isn't just about learning the facts. It's also about appreciating the incredible speed of medical innovation happening right now
Yeah.
and recognizing the real power that comes from making informed choices about health. It kind of leads to a bigger question, doesn't it?
Which is.
Well, in this age where medical knowledge is advancing so rapidly, how can each of us become a more active, more empowered participant in our own health journey and in supporting our loved ones? How do we best use this growing knowledge to shape better health outcomes for everyone?